Good morning, Americas. Good afternoon, Europe and Africa, and good evening, Asia and Australasia. My name is Steve Lacey, and I am the ISRRT Director of Education. Welcome to this April edition of the ISRRT monthly webinar series, where we're going to be discussing a very important topic relating to patient deterioration. Many of us do work with patients, sometimes without anyone around. And we do need to ensure that we do recognise when a patient is deteriorating and how we can then respond to that patient as well. So in today's presentations, we're going to be joined by Dr. Tim Agadakos from Greece, who will be discussing deterioration with respect to teachers, to reactions to contrast. And we will be then joined by Scott Cooper of Australia, who is a paramedic and will be talking us through how to respond to the deteriorating patient. As always, if you have any questions, please make sure that you pop them in the chat throughout, and we can go through those questions at the very end. So let's kick it off with Dr. Agadakos. So he began his professional journey in radiography in the late 1980s. After completing his tertiary education in Sydney, Australia, he worked for 5 years as a radiographer and ultrasonographer in private practices across Sydney. In 1995, following his relocation to Athens in Greece, he joined a large teaching hospital where he has since played a pivotal role in the medical imaging department, particularly in CT. He designed advanced protocols on a 128 MSCT system. He has benchmarked departmental diagnostic reference levels, or DRLs, against national standards, ensuring optimal performance and patient safety. And as the chief radiographer, Dr. Agadakos has been instrumental in numerous initiatives, including his involvement in the ISO working group and PACS committees of the hospital. Additionally, his contributions extend to public healthcare, where he developed technical specifications for medical imaging systems as part of public procurement processes. Welcome, Tim, and you may start your presentation. Thank you.
Welcome, everyone. Thank you, Stephen Lacey, for the introduction and the invitation. Whether you're a student, a junior, or a senior radiographer radiological technologist, this topic is relevant, urgent, and potentially life-saving. Today, we'll focus on the recognition and rapid response to anaphylaxis in medical imaging, especially around contrast media use. This is also a foundational talk that leads directly into the second presentation. Let's get into it. I do not have any conflict of interest to disclose. Today's objectives are clear. First, we'll set the context with epidemiology, what's changing and why it matters in medical imaging. Then, we'll zoom into what to look for, the early signs and red flags. We'll walk through contrast-induced anaphylaxis, emergency response steps, and how radiographers should document and escalate appropriately. Radiology has changed a lot in the last decade. The number of procedures using contrast media has risen sharply. With that rise, so too have contrast-induced reactions, including life-threatening anaphylaxis, which can occur in both outpatients and inpatients. Radiographers are often the first healthcare providers to witness or respond to early signs, so your ability to act fast even before the medical emergency team arrives can make the difference between recovery and tragedy. Several studies have shown that delayed recognition is a key factor in poor outcomes. According to the World Allergy Organization, anaphylaxis is defined as a severe life-threatening generalized or systemic hypersensitivity reaction characterized by rapid onset. The reaction is commonly mediated by IgE, but it can also be non-IgE mediated, particularly in cases involving contrast media. Now, in these instances, the response is atypical and unrelated to the pharmacological properties of the contrast agent, occurring due to unique physiological differences among individuals. This can result in unexpected side effects or toxicities, commonly referred to as idiosyncratic reactions. Key systems are affected. They are the respiratory tract, the skin, and the cardiovascular system, as well as the gastrointestinal system. It can progress to cardiac or respiratory arrest within minutes, and it always requires emergency response, typically epinephrine. Now, let's look at the epidemiology. It currently affects about 1.6 to 2% of the general population, with incidence rates reaching up to 30.5 cases per 100,000 person years in higher risk groups, such as children. Hospital admissions have significantly increased, reaching up approximately 9.5 cases per 100,000 individuals between 2005 and 2016 in the US. And while fatalities remain low, around 100 to 200 deaths occur annually, and there is an alarming rise in these cases during contrast-enhanced imaging, notably among older adults. Additionally, we see higher rates in children and adults aged 30 to 60, especially with repeat contrast exposure. These statistics highlight the need for awareness and preparedness in clinical settings. But why are rates rising? Why do we see more cases? What are the contributing factors behind all this? First, contrast-enhanced studies like CT angiograms are now routine, even in emergency departments and outpatient settings. Second, older patients are now on more meds, increasing the likelihood of sensitization to multiple agents. Third, mild reactions like itching or flushing are often missed or not reported, preventing flagging for future procedures. And finally, many imaging departments still lack a standardized emergency plan tailored for anaphylaxis, which delays life-saving treatment. Recognizing anaphylaxis early is vital. The earlier you act, the better the outcome. Anaphylaxis rarely announces itself clearly. It often begins subtly. Look for skin symptoms like hives, flushing, or swelling of the lips and eyes. Respiratory changes can include wheezing or difficulty in breathing, especially if there's airway involvement. A sudden drop in blood pressure, dizziness, or collapse may signal cardiovascular involvement. Gastrointestinal changes include nausea, cramping, vomiting, while patients may also experience a feeling of impending doom due to anxiety or panic attack. And on top of all this, symptoms and therefore anaphylaxis progresses fast, often within 5 to 30 minutes after exposure. That's especially evident in contrast media reactions, which may develop during or immediately after injection. You may also encounter biphasic reactions where symptoms return hours later without re-exposure to the contrast agent. That could be from 1 hour to 72 hours post-onset. However, the immediate reaction is the most dangerous, and death can occur in under 15 minutes without treatment. The key intervention is epinephrine, and it should never be delayed. Contrast media, particularly iodinated agents, are a well-known cause of anaphylaxis. Mild reactions like nausea or rash occur in up to 3% of patients. Severe reactions are rarer, about 0.04%, but potentially fatal. Although reactions with gadolinium agents have a lower risk, they are still possible. Importantly, contrast reactions can be IgE-mediated or result from non-immunologic mast cell activation, making them unpredictable. Even if a patient has had prior scans with no reactions, they can still develop anaphylaxis during a future one. While anyone can have a reaction, some patients are at a higher risk. These include those with a history of prior contrast reaction, even if it was mild. Asthma, eczema, and multiple drug or food allergies also raise the likelihood. It could be patients with cardiovascular disease or on beta blockers or ACE inhibitors may have blunted responses to treatment and more severe hypertension. And also repeated contrast exposure in a short time frame, that is multiple scans within a week, increase the risks. Now, these patients require extra vigilance. So it's critical to classify reactions properly, but always be ready for escalation. Mild reactions might just look like nausea or flushing, but if you see shortness of breath, wheezing, or swelling, you're already moving into moderate or severe territory. Severe reactions involve airway compromise, circulatory collapse, or even cardiac arrest. Even what starts as a mild rash can snowball into a full-blown crisis in under a minute. Okay, so now let's look at an example of what an anaphylactic reaction can do to the patient. Here's an intriguing case of sudden fatal anaphylactic reaction to contrast media, which was reported by Sapra and others in 2019. It involved a 45-year-old woman with a history of severe chronic obstructive pulmonary disease, diabetes type 2, and anxiety. She had no known allergies to contrast media. The patient was presented with COPD exacerbation and received treatment with prednisone and azithromycin. Despite this intervention, her symptoms continued, leading to a chest X-ray that revealed no significant changes. A CT scan with a pulmonary embolism protocol was then indicated, and tragically, during that scan, the CT scan, the administration of 60 mL of a non-ionic contrast agent triggered an unforeseen fatal anaphylactic reaction that resulted in a cardiac arrest. Pulmonary embolism was not detected, and the CT scans of the brain that followed indicated diffuse cerebral anoxia, and she was declared brain dead the next day. So as you can see, this case highlights the unpredictable nature of allergic reactions and emphasizes the critical need for vigilant monitoring. Okay, so here's another real-world example. A 58-year-old male came in for a routine CT with contrast. He had no known allergies, but he was also an ACE inhibitor. Within 2 minutes of injection, he developed a rash, then wheezing, and his blood pressure dropped rapidly. Thanks to the well-trained radiographer recognizing the signs and initiated the emergency protocol, he made a full recovery. This illustrates how preparation and rapid action saves lives, even in settings that feel routine. Now let's see another case study, an anonymized case, this time showing the dangers of underestimating early symptoms. A 45-year-old male presented for an MRI with gadolinium-based contrast. He developed a slight rash on his neck and felt nauseated during injection, but the symptoms were sort of brushed off as anxiety-related. No further assessment or intervention was initiated. About 10 minutes later, he complained of shortness of breath, had visible facial swelling, and his oxygen saturation dropped to 87%. The medical emergency team was called late. He was treated with epinephrine, antihistamines, and required temporary airway support. He was admitted to the higher dependency unit and discharged 2 days later. This scenario highlights a key point. Mild symptoms can evolve quickly. We must treat every reaction seriously and never assume that it was just anxiety or stress, just nerves. So let's compare the two cases. In case 1, the radiographer recognized symptoms early, called the medical emergency team, and treatment was started quickly, leading to an uncomplicated recovery. Whereas in case 2, where the symptoms seemed mild, so action was delayed, and they were sort of brushed off, and that delay led to respiratory distress, airway support, and a longer recovery. This illustrates why radiographers must be empowered to act immediately, even when symptoms don't seem textbook symptoms. Okay, so we saw that the case studies presented underpin the significance of our preparedness, of our alertness. Anaphylaxis requires immediate assessment using the ABCDE approach: airway, breathing, circulation, disability, and exposure to the trigger. Intervention should be initiated promptly and emergency services must be notified. Deaths often result from respiratory or cardiovascular compromise, so management should focus on these critical areas. As illustrated in the figure to your right, the management algorithm for anaphylaxis is comprehensive and it encompasses 3 distinct lines of intervention. It is crucial to recognize anaphylaxis quickly to enable the prompt administration of intramuscular adrenaline. However, it is also essential to adhere to national regulations and professional competency standards regarding the interventions we are authorized to perform as radiographers, radiological technologists. So when anaphylaxis is suspected, emergency response is necessary. Your first 60 seconds are everything. If you suspect anaphylaxis, stop the injection immediately, no hesitation. Call the medical emergency team or code blue. Don't wait for certainty. Anaphylaxis is a clinical diagnosis, not one that waits for a test. Lay the patient flat unless breathing worsens and give oxygen via non-rebreather mask. If you are trained and authorized, prepare epinephrine for administration. Epinephrine is the first and only medication proven to reverse anaphylaxis effectively. The standard adult dose is 0.3 to 0.5 milligrams intramuscular into the mid-outer thigh. Repeat every 5 to 10 minutes as needed, and don't delay epinephrine while setting up in an IV or grabbing antihistamines. Auto-injectants like the EpiPen may be used in some departments under standing orders or protocols. Remember to monitor the patient's airway, breathing, and circulation continuously, and always take into consideration the national regulations and the protocol of your department. Do not perform procedures that you're not supposed to. Dear colleagues, keep in mind, you are not just the radiographer. You are actually the first responder in the room. You are responsible for recognizing the red flags, calling for help, and starting initial management steps. Document what time the symptoms began. You may forget in all this chaos going on. Report what was given and any known patient history. Stay with the patient, provide reassurance, and assist the medical emergency team or the emergency team. Good communication and a calm presence can be as life-saving as any medication. By no means, when a patient is stabilized, the process stops. The process does not stop. Patients must be monitored for at least 6 hours or longer if symptoms were severe. You need to complete a detailed incident report, and this is vital for quality assurance and future care planning. Ensure the reaction is flagged in the patient's record, especially if they need imaging again. Finally, debrief with your team. Ask what worked well, what could have gone better. Every event has a chance to improve. This is part of continuous quality improvement, and always you need to consider patient safety at all times. Okay, so let's recap the key points, what a radiographer, radiological technologist needs to know. Anaphylaxis may be uncommon, but when it happens, it's urgent and dangerous. Contrast media, especially iodinated agents, are known to trigger. You can't eliminate the risk of anaphylaxis. Being proactive can make all the difference. Minimize exposure and stay prepared for the unexpected. And, it's always safe to use those ESUR, the European Society of Urogenital Medicine, questionnaires prior to selecting your patient for contrast media examination. Radiographers, keep in mind the radiographers are frequently the first people in the room when symptoms begin, or they should be. And that makes you critical to survival. Epinephrine is the only first-line drug, so don't delay it. And most of all, always remember the 3 R's. Recognize, respond, report. So what happens when anaphylaxis strikes? You need to take action. So here are the practical checklists. Commit to this to memory or keep it in your department. Stick it up on a wall somewhere. Have it in a place where you can see it at all times. And this is what the action looks like. This is your checklist. Stop the trigger. Stop the contrast media injection immediately. Stop the imaging procedure. Call for help. Position the patient flat, as we already mentioned, unless they have breathing difficulties. Give oxygen. Give epinephrine if trained. Always adhere to the regulations, the national regulations, and your protocol guidelines. Then you need to stay calm. Stay with the patient. Document clearly. Remember the time that the incident occurred, and hand over thoroughly. You've got this. So the key takeaways for today's presentations are that although radiographers may not always get the spotlight, your role in emergencies is vital. You are not just the radiographer. And in some countries, you are not just the tech. You are often the first line of defense. You need to make a difference. Stay alert. Stay ready. Be proactive. And, let's continue building safer systems for our patients and for each other. But what happens if the patient doesn't respond to treatment? Or what if the deterioration isn't allergic in nature? from acute allergic response to patient deterioration. You may have a patient with seizures, hyperglycemia, cardiac events. These happen too. Well, these will be discussed in the next presentation, and I'm certain that the next session will give you even more confidence in crisis scenarios. Here's a snapshot of the references used for today's content. And just a quick note before we move on. Dear colleagues, don't forget to join us at the ISRRT World Congress in Dubai in 2026, October 27th to the 29th. So do save the dates. Thank you for your attention.
Thank you, Tim, for that wonderful presentation. That was very, very important, but a very, very good presentation nonetheless as well. Just a reminder to everyone to please put your questions in the chat if you have any questions that are coming up that we can ask both Tim and Scott at the end of our session. Let's introduce Scott now. Scott spent 16 years working as a radiographer before pursuing a career in paramedicine. He's an Australian registered paramedic and holds a non-practicing registration as a radiographer. He's the manager of clinical education for Queensland Ambulance Service, Far North region, and is passionate about improving the knowledge, competence, and confidence of medical radiation practitioners in emergency response and patient care. Scott is a good friend of mine and has done a lot of work with ASMRT as far as recognizing and responding to the deteriorating patient, and I'm very, very pleased to have him on tonight and giving this presentation for us. Thank you, Scott.
Hello, my name is Scott Cooper. I want to thank the ISRRT for this opportunity to discuss with you the Deteriorating Patient Program, which is something that I've put together to aid and assist medical radiation practitioners in detecting early deterioration in their patients. I'm a non-practicing radiographer and a current practicing paramedic with the Queensland Ambulance Service. And I'm very passionate about this title because I think there's definite scope to improve our abilities and capabilities in this area as MRPs. Now, it wasn't that long ago that AHPRA revised their professional capabilities for MRPs in section 1.7, which specifically covered the need or the recognition that MRPs should actually be able to recognise patients when they are deteriorating and respond in an appropriate and timely manner. This is two-factor. It needs, obviously, the clinician to actually identify, first of all, when the patient is deteriorating, and then also to take the appropriate and timely action, which may require getting further support or help. Often we hear MRPs say that that's not really their business because that's mainly for doctors and nurses to look after that field of care. However, it could be argued that realistically, patient safety is everyone's business. Anecdotally, from my perspective, I think there has been a shift over the last probably 10 to 15 years, even 20 years, of the expectations of MRP trainees when they come through university. I remember that there was a much bigger focus, and it was kind of like the capstone, I guess, on practice was our soft skills in terms of communication, empathy, and critical thinking skills, followed by technical skills and then the academic knowledge. I can't help but feeling now, though, that's kind of been turned on its head, with academic knowledge being the sort of priority of universities, technical skills coming second, and then the soft skills coming in third at the bottom, which is now being almost crushed, I feel, at the expense of the other areas of training. And I'd like to see that flip back on its head so we can improve our soft skills. When it comes to MRPs, I believe that they are a highly skilled collective, and there's only a minimal amount of training that would really be required to enhance their awareness to detect the early signs of patient deterioration. And given their proximity to their patients and the extended interactions that they have, I think it's very obvious that they're well suited to actually detect deterioration rather than relying on doctors and nurses. So if we can promote the integration of this training into the MRP practice, I think we'd see an increase in their confidence and competence, and also they'll be able to recognise and proactively advocate for their patients and feel more part of the healthcare system as a whole and their journey. I guess I want to reiterate as well that it's not about these types of patients, the ventilated, intubated patients who come down with 6 nurses and 3 doctors. It's about these ones that are generally well and don't really have any obvious signs of deterioration or illness. These are the patients that we really need to be focused on. So there's a number of standards and advisory bodies in Australia that we can turn to who do actually provide some advice on what patient deterioration detection looks like and what methods we can use to actually detect it. And one of them is obviously the Australian Commission on Safety and Quality in Healthcare. And when it comes to detecting and recognising acute deterioration and escalating care, their statement is that monitoring and tracking changes in vital signs and other observations over time plays a significant role in detecting acute deterioration. And acute deterioration may occur any time during a patient's admission, which is very important remembering that because it could be during the time that they're in the medical imaging department. Next up is the slippery slope, and this is a graph that's provided by the New South Wales Clinical Excellence Commission. And what it basically shows is that we need to respond to a patient deterioration between those flags or even before, because you know that the earlier we intervene with patient deterioration, the better it is for them and the decrease in patient morbidity and mortality. So with training up MRPs to actually be able to early recognise deterioration, we can increase patient safety and again hopefully see a decrease in morbidity and mortality from hospital patients when they do deteriorate. So the question will be, how do we recognise patient deterioration with MRPs without significant upskilling? We don't obviously want to train them to be nurses or doctors, but what we do want to do is provide some degree of education that can help to boost their confidence and their abilities in this area. So my 3-stage approach that I am advocating for is basically, first of all, raise awareness. So that's providing basic education on causes and things like that. Applying a curiosity mindset is a slightly different approach than I think most MRPs would be used to, whereas it's more functional and sort of task-based. And then training them to actually do some analog observations. So again, very simple methods. So exploring the first one of raising awareness, what we can do is we can break it down into specific areas of deterioration or causes, looking at cardiovascular, respiratory, neurological, traumatic, and also exploring some of the risks of sepsis and anaphylaxis, which is a very obviously current topic, with sepsis being one of the primary causes of deterioration in hospitals. And anaphylaxis is also very prudent with MRPs administering agents that can initiate anaphylactic reactions. Out of this, when we look at cardiovascular causes, we can talk about arrhythmias, acute coronary syndrome, pulmonary embolus, respiratory, asthma, APO or acute pulmonary edema, and pulmonary contusions. We're not talking about training MRPs to do bloods, to look for troponin leaks or doing ECG recognition and diagnosis. What we are talking about is what these conditions look like in a patient and the red flags that are associated with patient deterioration that they can detect easily and rapidly. When it comes to traumatic and neurological, we look at things like tension pneumothorax, internal hemorrhages, intracranial hemorrhages, which can also fit into the neurological causes, of course, CVA, be it a stroke or TIA, and seizures as well. And having an awareness of these possible causes of deterioration and the pathophysiology behind it will hopefully enable the MRPs to be much more confident when they do see it. So the curiosity mindset is something that I'm quite keen to explore with MRPs and see if we can actually get them to change slightly the way that they approach their tasks and everyday duties. We know that clinical curiosity is a very important factor in the early recognition of patient deterioration. And if we can get MRPs to transition from a task-focused automated mindset to one of curiosity and engagement, we know that can promote empathy, improve the quality of clinical decision-making, and promote reflective practice, and also encourage that really important critical thinking. It doesn't require much of a time investment, and we know that actually reduces burnout with medical professionals, and also can stimulate lifelong learning. So again, rather than seeing patient as an ankle or a foot or a head scan that we tend to say these days, it's more about the patient and their condition and exploring that. But we'll talk more about that later on. I just want to Go now to the analog observations that I'm talking about, which is the third step. Now, when we look at the National Consensus Statement on Patient Deterioration, they identify a set of 7 core vital signs, and they recognise those as being essential elements for recognising and responding to acute physiological deterioration. So those 7 vital signs are respiratory rate, oxygen saturation, heart rate, blood pressure, temperature, level of consciousness, and new onset of confusion or behaviour change. And if we break those down, we can easily train MRPs to rapidly and easily identify changes in 5 of those, that being respiratory rate, heart rate, temperature, level of consciousness, and a new onset of confusion or behavioural change, without any additional upskilling in uses of machines, even though these are very simple, such as the sphygmomanometers, the automatic sphygmomanometers, and also the SATS probe, which can be very quickly applied. So we could also obviously extend into those other 2 areas if we needed to. So the 6 critical analog observations that I'm proposing that we need to probably get MRPs to focus on are: number 1, pain level. Is the pain increasing or decreasing? Number 2, heart rate. Is it tachycardic or bradycardic, fast or slow? We're not worried about, again, diagnosing ECGs. We're just worried about whether the heart is fast or slow. The respiratory rate, rhythm and effort. The level of consciousness and behaviour of the patient, and particularly detecting changes in that. The skin temperature, colour and moisture. Again, the skin is a very good organ for detecting early deterioration, and with simple training we can get our MLPs to recognise when there may be underlying or occult deterioration at play. And then the last one is gut feeling, which is actually very important in medicine, as we all know, and we'll discuss these a bit later on and the red flags that are associated with them. So red flags are obviously clinical indicators that are of concern, and one of the best things about patient deterioration monitoring is that they're fairly similar across the board, and that we don't need to be able to specifically diagnose something, but we do need to be able to recognise red clinical flags so that we can actually say that the patient may be deteriorating. And if we start with the heart rate, what we're looking for is either a pulse rate of below 50, heart rate of above 100, or if the pulse is irregular. And we're not saying that these are obviously indicators of definite deterioration, but what these are is potential red flags when put in context of the patient's presentation may or may not indicate deterioration. Moving on now to respiration. If we see an increased rate or effort of respiration, that's obviously a red flag. Any shallow or slow respiration is a red flag, and any abnormal or bizarre respiration. We can also train MRPs very quickly to recognise the physical signs of respiratory distress. In this next video, I'm going to show you intercostal recession, which again is a sure sign of respiratory distress that the patient's working very hard to breathe. This is a very easy observation to make by any MRP, and obviously they can be trained to then recognise this as representing respiratory distress in their patient. Taking peds now, we can look at this patient here, which has got a very young patient who's got tracheal tugging, which again is an indicator of respiratory distress. And if we can train MRPs again in recognising this kind of thing, we can hopefully get on top of it early and get treatment earlier on. Looking at the skin now, we can talk about skin condition, whether it's pale, mottled, whether the capillary refill in the thumb bed, just by pressing on the thumb bed, is less than 2 seconds. We know that that could indicate peripheral shutdown. Whether the skin is cool or hot, literally talk about just placing the back of the hand on the forehead or part of the of your body on the back of the forehead. We're not talking about taking temperatures, but obviously that would be very quick and easy to do if we did do that. And also if they're clammy, so if they've got that diaphoresis, again, is a potential indicator of patient deterioration. With pain, we're worried about any sort of pain that's above sort of 7 on a 0 to 10 scale. If that pain is actually increasing, again, if it's increasing rapidly, is a very big red flag. And lastly, if it's abnormal for the injury. So if the patient's got, say, pain from a fall in their elbow, but they're now having chest pain, again, that's a significant red flag. With the level of consciousness, we're looking at things like decreased consciousness, abnormal behaviour or confusion that could be, again, indicators of a deterioration in the patient. And then gut feeling, which I think is a very important part of medicine and sort of risk identification and risk stratification. So if you're concerned, if you just have a gut feeling, you're worried about the patient, if the patient is concerned, if they've verbalized that they feel very unwell or they feel like they're going to die, and also if a parent or a relative is concerned about the patient as well, should definitely be considered red flags. And things like the FAST test is obviously a very simple and well sort of known tool where it can be very easily applied by MRPs, in particular to detect things like stroke or TIA that may have occurred whilst the patient's within the medical imaging practice. So let's get back to curiosity mindset now and the importance of that. So we're going to look at a couple of case studies and basically we've got two different approaches. The first one will be like a closed mind approach, and then the second one will be a curiosity approach. So our first one is Rachel, who's arrived in the ED department for a head CT. You haven't seen the referral yet, but you just know that she's there for a CT head. And as the MRP is willing the current patient to have CT, they notice that Rachel is wincing and rubbing her chest. They stop to ask if she's okay, and she replies, "Yeah, I'm okay, thanks." So our first approach is going to be one of a closed mindset, where you basically you hear that she's okay. She said she's okay. You're happy with that. You explain you've got one more X-ray to do, and then that she's next. So you head off to do this X-ray, but it takes a lot longer than you thought it would do because it's a bit more complicated. And when you do eventually get outside, you notice that Rachel is slumped to the side. You get closer and you realise that she's unresponsive, breathing in shallow gasps. She's pale with blue lips, and you don't think you can feel a pulse anymore. So you immediately activate a MET call or call 000, which is the emergency response number in Australia. Now, if we flip that around and look at a curiosity approach to that, or a curiosity mindset, in this case, Stephen's now asked basically how she ended up in hospital once he noticed her rubbing her chest and looking like she was in pain. She explains that she was in a motorcycle accident this morning, was supposed to be going home, but then she got a bad headache and blurred vision, so they sent her for a scan of her head. And I've highlighted there the areas that are red flags. So we know they've got trauma, they were supposed to be going home, but now they've got a bad headache and blurred vision. With that, Steve then asks, that she seems to be in a lot of pain, so explores that a bit further. And Rachel explains that headache's mostly gone, but now she has a really bad pain in her chest, saying that she probably just cracked some ribs, which again, you could walk away at this point and ignore that. But in reality, we've got Steve here, who's a very good practitioner, and he asks her to describe the pain to him. And she says that the pain's been getting a lot worse over the last half an hour. Another red flag there. It's making it hard to breathe. Another red flag. And she's asking for more pain relief, which is another red flag as well. So what he does now is he just takes her pulse and her breathing rate and asks her to rate her pain on a scale of 1 to 10. And the results you get are that her heart rate's 120, her rest rate's 30, and her pain's now 8 out of 10. And he knows that's not normal for someone who's just sitting in a chair. So Steve's now thought is that her heart rate's very elevated, she's having trouble breathing, and her pain's getting worse. With a history of chest injury, he's now worried that she's deteriorating. And obviously when she's assessed, they find that she has a significant tension pneumothorax that requires decompression in ED. Second case study now is going to be about Brandon, and he's a 14-year-old male who attends the medical imaging department with his dad for an elbow x-ray. He's come off his e-scooter and he's got a reduction in movement of his elbow. As you approach perform the study, you notice he's looking a little pale and sleepy. You bring him into the x-ray room where your fourth-year student you are supervising will perform the x-ray. Again, with a closed mindset, you get your fourth-year student to do the x-ray because you know they're very capable of it. And you basically are not really paying much attention, but you soon hear that the student calls out that the patient's nauseous. So you tell them to quickly do the AP and you'll grab a sick bag. You go back in and give the sick bag to Brandon, and you tell his dad that they can basically wheel themselves back out into the waiting room while you check out the x-ray. And you spend a few minutes with the student discussing the x-ray, looking at the radial head to see if there's any cortical disruption. After about 5 minutes, you hear a cry for help and you find Brandon unconscious on the floor, and you immediately activate a MET call. Again, let's spin that around now. We're going to be looking at a curiosity mindset. So in this case, Dewani, one of the radiographers, just asks what happened to the young lad. And he explains that he was doing a jump on his scooter, but he fell, landing on his elbow. Again, jump on a scooter is a red flag. There's trauma involved. She asks how he's feeling because she noticed that he doesn't look himself. And he explains that his elbow hurts the most, but now his guts and right shoulder really hurt as well. And he also feels like he's going to spew, which again are red flags because he's got abdominal pain, right shoulder tip pain, and he feels nauseous. So we know we've got these red flags now. that are indicating something that's going on. She asks that his dad, whether he normally looks this pale, because that obviously establishing a baseline can sometimes be important, and he explains that he's never seen him look so pale. So what she does to Arnie is she takes his pulse, and she also says that because he said his tummy was sore, she just asked him to lift up his t-shirt and take a look. He knows his heart rate is 130 and his pain's 9 out of 10. And this is actually based on a real case that occurred in the hospital where I work, where this injury was missed on initial presentation. So when she has a look at his abdomen, she notices there's actually a wound or an injury to his above his liver. And what's happened is, as he's fallen off, the handlebar from the scooter has actually penetrated or hit him very hard in the abdomen around the liver area. So again, Duania, with her training, she recognises that his pulse is very fast and feels weak. He has abdomen pain and shoulder tip pain, which is indicative of peritoneal irritation, potentially from blood. And she's concerned that he's deteriorating. And the CT, again, in the real patient, this is not the real image of the patient that I dealt with, but this is obviously a CT laceration that was picked up. Luckily, the young lad survived and did well post-surgery, but it just goes to show that these can be missed by even the most experienced physicians in hospitals. And that ends my talk, so I will finish this now and be available for any questions should you have any, but thanks very much for your time.
Thank you, Scott, for that wonderful presentation. Always a good one, and I really enjoy seeing all of the different responses that can be done as far as a deteriorating patient is concerned. I'd like to invite Tim and Scott to both put your cameras on, and we can go through a little bit of a Q&A. And again, just to encourage anyone who has any questions to please pop them into the chat so that we can go through them during this. I do have some questions already to begin with. Tim, to start with you work primarily in CT in your role over in Greece. How often do you see reactions to contrast in your work?
Not too often, because what we try to do is we utilize the preparedness. So we use a questionnaire provided by the ESUR, the European Society of Urogenital Medicine, and we get patients to reply and check all these boxes for the contrast media, risks, so we can minimize the risk of reaction to the iodine. The thing is, sometimes people don't answer the boxes, so usually the training radiologist or a radiographer will go through the questionnaire with the patient or the person accompanying the patient. But, that's just to safeguard. Sometimes we do have reactions. I would say that they range from mild reactions, 1 to 3 a month, because we do use this questionnaire, which helps, and we use low contrast media volume in patients, which is also something that could help, reduce the patient risk to idiosyncratic reactions. But I would say 1 to 2 patients per month.
Yeah. And you talked a lot about in your presentation about for those who are trained to do so is giving epinephrine. What are your thoughts about radiographers and radiation therapists legally being able to do that? Because it can be a controversial topic in countries like Australia at the moment. It's quite a controversial topic in terms of radiographers injecting things like adrenaline and epinephrine and that. So what are your thoughts about that, Tim?
Well, this is a personal opinion, and I'm happy to share it with you. If you have someone that's actually educated and trained well to do so, then they must do it, because you need to respond early in order to begin treatment early. And there are cases where you don't have a radiologist right next to you. They may be in a back room doing some reporting work, or the nurse is with another patient. It all depends on your workflow and the conditions in your department. So I think it's best that you get more people to be trained to do so, rather than stay away and hide behind the regulations. When I say hide, this is in in brackets. The thing is, you need appropriate and adequate education to do so.
Yeah.
We have an issue in Greece where radiographers, even though they're at the highest level of the European quality framework, they're at a bachelor's level, they cannot administer contrast media yet. In CT where I work, radiographers are the ones that use the injector pumps, and they actually administer contrast media to the patient intravenously. So they need to observe the patient and respond quickly.
Yeah.
Don't miss the mild reactions. It's very often. I mean, it's happened to me. You always because your mindset is to provide a diagnostically accurate exam. So you're injecting the contrast, and your patient is having a mild reaction, and instead of stopping it, you're trying to get some more time to visualize the pathology, and that way the mild reaction can escalate and become, intermediate and then severe. And, we need to get our priorities right.
Yeah, yeah, absolutely. Thanks, Tim. Scott, a question's come through from Ashley. Thanks, Ashley, for your question. Scott, have you encountered a scenario where a colleague dismisses your concerns of patient deterioration or has a different opinion? And if so, do you have any advice for escalating when a colleague does see the urgency differently?
Yeah, that's a really, really good question. And it's certainly something that I think we see both as a paramedic, and I did see when I was a radiographer as well. And indeed, it occurs in hospitals all the time, differences of opinion between, doctors and nurses about whether a patient is unwell or is unstable. So crisis resource management principles have been used in high-risk industries for many, many years, anesthetics primarily, aviation, mining, military. It's kind of been widely adopted, I think, by these high risk areas. But it's definitely a value to MRPs as well, and it's something that I do push for in the training I offer over here. I do actually push for or provide some sort of base level crisis resource management training, and part of that is graded assertiveness, which is speaking up when you do have concerns. If you, I'm sure that every single hospital, pretty much across the Western world, has policies to stipulate that you are responsible for patient safety, that everyone has a responsibility within that sphere. And speaking up and voicing your concerns is critical. It doesn't matter who you are. It could be the cleaner, it could be the wardsman, it could be the radiographer, but we have an obligation to listen. And I think we've seen sort of a transition over the last 20 years in medicine where, the ego and, doctor is God and she'll never be questioned has kind of gone by the wayside. Maybe not in some parts of the world, but I think we've gone away from that. And that's very valuable. It's definitely increased the safety. So if you are concerned and you do have discriminating colleagues, I think you absolutely have the right to voice those concerns. And if ever you are concerned and you're being dismissed, then it's always wise just to get a second opinion or to find someone else to voice those concerns to. That can be very difficult. I appreciate that if you are a quiet person or not, comfortable with conflict. But there are graded assertiveness tools you can use, such as the PACE model, which if you just Google PACE model graded assertiveness, you'll be able to do some research on that, which helps you kind of step through the process of questioning someone who may be dismissing you. But yeah, it's a very, very good question. It can be very difficult.
I have another question for you, Scott. Let's cast your mind to a newly graduated radiographer who is now working relatively isolated in a rural setting, and they are in a situation now where they have a patient who's deteriorating. So it's obviously a very, very highly stressful situation for them, and being, inexperienced, I guess, and not necessarily untrained, but certainly inexperienced in that. Any tips for them about how they can avoid panicking in that type of situation? I know that if I was a newly graduated radiographer, I'd probably panic if I had a deteriorating patient right in front of me and I wasn't able to call upon anyone in that. So how can they avoid panicking?
Yeah, another great question, and I think it's really, it doesn't sort of matter really how much I guess knowledge, tools, and information you put on it. Whenever you're faced with it for the first time, it's terrifying. I remember thinking that I understood anaphylaxis when I was a radiographer until I was a paramedic, and I started to see anaphylaxis, much more frequently, and I realized I had no idea. And it's terrifying to witness someone actively, deteriorating in front of you, and knowing that if you don't interact, they could have some serious ramifications. So the only real way to actually overcome that is to be confident, and you always tend to deteriorate to your lowest level of training. So if you've got a base sort of level of a checklist or a plan, it's very good what Dr. Kim was talking about putting up posters around the place that are basically, if you reinforce that knowledge so it becomes muscle memory, that if this happens, then this. So, know the number for the Met team, do a first aid course or certificate, know where the oxygen is, know where the crash cart is, so you can actually repair, organize the scene so you can send someone to meet the ambulance or the Met team when they arrive so they can find where you are, especially if you're in a large facility. So if you put those systems in place, and you practice them, you definitely have a much better chance of actually being able to respond. And it really is that practice. I think so often what we do is we do these mandatory training packages, we do it once a year, and we don't really pay much credence to it. It's like an insurance policy. It'll never happen to us until it does. And we know that the sort of low volume, high frequency training is the best model for retention of information. So one thing that I suggest when I do my training, Lexus training to people, is when you go back to your departments, is just maybe during your CT warm-up or whatever, or when you're 10 minutes before you start your day, is just go to everyone, okay, stop. We've just had an anaphylaxis in the CT room. What do we do? And just get people to talk through that, think through that. And if you make that part of your regular routine, eventually it becomes so ingrained that people just know what to do. But if you're a very junior staff, it can be extremely challenging. But again, if we empower them to know what to do, to make sure that if they, when they start the practice, they do know where the emergency phone number is, know where the crash cart is, I think they're in a much better position to actually respond to that. But I don't think you'll ever get away from that. And it is a normal reaction to an abnormal situation. We have to understand that. But
Yeah.
preparation is definitely the key in practice.
Thank you, Scott. I was actually going to add to that as well, which I think you did kind of speak about a little bit, is encourage, I guess, your local teams and that to do regular simulations in that process. I think the more simulations that you do and your basic life support training and things like that, I think that can also help in those types of situations as well to help to reduce the stress, because then it's something that you're used to seeing. It's almost like a second nature thing in a way as well. So yeah. Now, before we came online today, the three of us were having a bit of a talk about the importance of this particular topic and how it really resonated, I think, a lot with radiographers, radiation therapists, and that. This is, I guess, a question for both of you. What further work do you think that we as radiographers and radiation therapists can do to help reduce the effects of the deteriorating patient? Something that I guess helps us to understand it a little bit more and reduce the effects, or reduce. I mean, Tim, you talked a little bit about preparedness and making sure that you're preparing someone as opposed to reacting to them having anaphylaxis, but inevitably it's going to happen anyway. Is there anything further that we could potentially do?
I think the only thing we can do, as Scott already mentioned, is be proactive. And I rather liked that we deteriorate to our lowest level of education, of knowledge when this happens. It's something inevitable, which means we cannot avoid it. And perhaps only have some simulation drills and do this, what we're doing now, webinars. And maybe we can do some hands-on webinars on sites, simulate an anaphylaxis or a deteriorating patient, and how we can cooperate with other healthcare professionals. Because what I find, when this thing happens, you may not panic, but another health professional may panic. So how do you cope with this? And sometimes we run into the CT examining room and we just crash into each other because we don't know where to stand. So the first thing to do is know your position in the CT room, or in the X-ray room, or wherever this may happen in the medical imaging department. Know where to stand. Know what you must do. So you're a key member of a team. So the team must work well. You cannot practice as radiographers by yourself. You need to do the drill with other healthcare professionals, with your nursing staff, with your radiologist, with your with your junior radiologist, with your anesthesiologist that may come down, or your cardiologist, with the medical team that comes down. Know where your position is. I think this is the first thing that we need to do. Realize that we're not managing this reaction ourselves. We're at the very initial step, but then when this escalates and you get more members coming in, more healthcare professionals coming in, you need to know what your duties and responsibilities are. And sometimes you may need just to give the tasks to the next the next healthcare professional that will need to give the epinephrine, for instance, or start the defibrillation. I mean, I don't know how this will escalate, but you really need to know where to stand when this occurs. This is very important.
Yeah,
Yeah,
Scott,
I
did you have a
completely
response? Yeah.
agree. Yeah, I think that knowing where you are, what role you play in a team is critically important. We know that high functioning teams basically have a leader or someone who actually directs the team, and I consider that to be like the director in an orchestra, almost, who actually controls the team and keeps an eye, has that sort of situational awareness. Because we know when you get that cognitive overload, that your higher thinking centers shut down, so you're not rational. So practicing can help with that, but knowing your place in the team can also help. And as you rightfully pointed out, little things like information such as the patient's medication or past medical history. So as your Met team rock up, it's really critically important that they know if that patient's beta blocked, or they know if that patient's had GTN, because the treatment that's given can sometimes be ineffective with those true medications, or if they're asthmatic because they've got hyperactive airways. So knowing that knowledge is really important to pass on, because if they're giving adrenaline and it's not working, they'll know why, because the patient's beta blocked. It makes a big difference. So little things like that. But I think from an institutional sort of level, and I can't obviously speak for other states or countries, but I think radiographers for too long, MRPs have been marginalised into, that's your role. You just take pictures. Don't bother me with anything else. And I think we really need to shift away from that and start integrating wider with the healthcare, team, and being part of the patient's sort of journey and being recognised as such. Some incredibly intelligent, smart people who are more than capable of detecting deterioration, of giving an EpiPen. It just blows me away that, radiographers and MRPs cannot give an EpiPen. It's something that we train kids to do, like 5-year-old children. So why on earth can we not train MRPs to recognise and give adrenaline? Because as you rightly pointed out, those first 30 seconds to a minute are critical, because that adrenaline not only addresses the symptomology, but it also stops that degranulation of the mast cells. So it actually stops the reaction from getting worse. And that's why it's so important to get in early. So I think, professional bodies like the ISRRT and asthma can probably hopefully push this as an agenda to increase patient safety.
Yeah. Thanks, Scott. That was a good answer. Another question's come through from Mina. I'm actually probably going to be able to answer this myself. And the question was about what is the scope of the Bachelor in Radiology. And I think that really depends upon which country you're from. And I would probably encourage people to understand what that scope is based on what their country's regulations are. Another question has come through from Min, and thanks, Min, for your question. Min and I obviously thinking along the same lines, because I had the same question written down myself as well before she popped it on there, and that is about the well-being of the radiographer or the radiation therapist who is the first responder to the deteriorating patient. So someone who's actually gone through that process and that. What about the support for those? What mechanisms do you have in place to support these people post that event?
I guess I can obviously apply this to the paramedic world, where we often, have traumatic events quite regularly that are quite confronting. A debriefing is such an important part of that, and something that's often remiss. My wife came home after work, and where there's an arrest a cardiac arrest in the department recently, and whilst to paramedics, to ED people, it's an arrest is run of the mill. It's like it's not really a big deal. It doesn't really register on our radar. But we forget that if that's the first time you've seen someone, having compressions, or you've even been part of that resuscitation, that can have a huge psychological impact. So I think that debriefing post event is really important to reassure the person they've done the best that they can, that they were helpful, and also just to get them to check in on their mental health over the next few days. Getting them to recognise that, again, that maybe having flashbacks is actually a normal coping mechanism. But if it's going on for more than a few days, it's probably not. So at what point they should seek professional intervention from a mental health professional. And again, it's something I think that gets ignored and not recognised as much as it should do.
Can I add to the complexity of that question as well and suggest that often you might have a night shift radiographer, for example, that is working on their own. They may have a deteriorating patient or an anaphylaxis patient that they've had to attend to at 1 o'clock in the morning. And then straight afterwards, they have to go back to work. They don't have time for a debrief or anything like that. What should those people do to actually get through the rest of their shift in order to make sure, but still make sure they're managing that workload?
Yeah, self-care is really important. And we used to stand paramedics down if they attended like a pediatric arrest or something that was very traumatic, we'd actually stand them down mandatory. But what we found was, or what the research shows, that that's actually not the best thing you can do. Because we send them out of the workplace, they go home and think about it. So sometimes just re-engaging with work can actually be beneficial. But I think we have to have some notification structures in place so that the manager or the supervisor can be notified that this has occurred, and then that follow-up occurs by a suitable person, and maybe a referral to one of the social workers or to one of the psychologists if you have those on staff, just to follow up with them and give them a phone call. We have something called peer support in the ambulance service, where we have paramedics who receive a text message when something happens that's traumatic, and they'll actually reach out and give the other paramedic a call to say, hey, just checking in, how you're traveling, something as simple as that. And that usually suffices to sort of initiate that conversation piece and detect if there is any issues that are going to be potentially damaging. But it is challenging. It's speaking again from my perspective, it's so ironic that 1 minute you can be dealing with a horrific traumatic cardiac arrest, and then literally half an hour later I'm talking to Nano who slipped over on her foot. It's just such a weird job, I guess, and same with all medical positions. But yeah, it's a good question.
And it's also hard to think that, your patient, your next patient has no idea what you've just gone through as well when it comes to your work. They have no idea what you've just seen and what you might have been exposed to as well. I've got a couple more questions to go before we finish up. A question's come through from an anonymous person that says, what position should the patient be in case of nausea and vomiting? Should they be sitting or should they be in a left lateral decubitus position?
So it depends on the conscious level. If the patient has any degree of unconsciousness or altered level of consciousness, then my preference would be to place them in the lateral position or the recovery position so that we don't soil the airway. We know that any kind of aspiration or pneumonia post aspiration and vomit is extremely damaging for the patient and can lead to worse outcomes. So we really want to protect that airway. And same for positioning if they've got both hypotension, low blood pressure, and shortness of breath. We always go back to ABC every single time. So airway is top of the list, B is next, and then C is after that. So breathing comes before circulation. So if they've got respiratory difficulties plus their blood pressure is low, we're going to preference the breathing, which may mean we actually sit them up just to take the pressure off the diaphragm to increase their or decrease their work of breathing, which may be at the expense of their circulation. But again, we have to preference that. But great question.
Yep. And one final question from Kadana, who has said, good morning from Trinidad and Tobago. Good morning, Kadana, in Trinidad and Tobago. A long way from Australia, that's for sure. Kadana says, hi, Dr. Tim and Scott. Do you believe these capabilities and simulations mentioned today should be incorporated into the radiography students' curriculum or just be done as part of the continuing professional development post-qualification?
Just say yes, and I'll pass it over to Dr. Tim for his opinion. But yeah, absolutely.
Yep.
Of
Tim?
course, I think this should be incorporated in the undergraduate program. Yet that does not mean that we should not do it as part of our CPD, because we get new data all the time, trends change, so we need to be updated all the time. So just by having it in the undergraduate program does not mean we're fully prepared. We need CPD for it as well. And people forget, if you're working in a department where you don't come across these kind of reactions, there are departments like, you may be in a DEXA program, or no, not mammography now. Mammography uses contrast media as well. You may not come across these idiosyncratic reactions, so you forget what you've learned during your undergraduate program. So CPD is vital, and should be both. That's my personal opinion. It should be both.
Yeah. I think as well, students, we have to remember that students are out on clinical placement. And so they're actually seeing patients. And so they do need to recognize that deteriorating patient. I mean, the students are being supervised, but there may be times where they are actually the first person involved in actually seeing the patient and needing to recognize that before actually calling upon some help in that. So recognizing that and responding to it, I think, is actually really, really important as well. Tim and Scott, thank you both so much for joining us today in this webinar. A very, very important topic. I think we've covered it in a lot of detail. We've done it really, really well. I would like to just remind people that if you're looking for a certificate of attendance for today, then that can be downloaded after 2 weeks from the webinar. And there's a website that Udapon has put into the chat. So if you're looking for the website about getting your certificate, then please pop into the chat and have a quick look at that one. A reminder, and thanks Tim for the reminder as well, but the reminder for everyone that the ISRRT World Congress is going to be in Dubai in 2026. We are currently accepting abstract submissions for this all the way through to December 31st. So if you're interested in presenting at the World Congress, then please submit your abstract. And if you want to submit your abstract, just go to isrrtdubai.com. Our next webinar is going to be on May the 21st, and this will be on weight bias and stigma in radiography and radiation therapy, which is going to be brought to you by our friends at the Canadian Association of Medical Radiation Technology. And please mark that date in your calendar, May the 21st, because I think that will be a really, really good one. Tim and Scott, thanks again for joining us. Thank you to everyone for joining us online.
There is one more question. Sorry, Stephen. There's a late question. Anonymous attendee. I think it has actually been answered live. It's concerning whether a patient has had an allergic history to contrast media and suddenly suffers an anaphylactic condition during the CT scan. So this is really important. That means we either missed the patient history, which means that we weren't aware of the patient history, which means we did not ask our patient, which is an issue. Okay, that shows that we don't follow policy and departmental guidelines. But if this does occur, and you know that your patient has allergic history to contrast media, the first thing to do is prepare your patient in order not to have the anaphylaxis reaction. But that does not mean that a patient that has never had an anaphylactic reaction to contrast media may not have, during your scan. So it doesn't mean because you know that your patient has never had a reaction to contrast media that he or she may not have it during the injection. Now, what should we do once the contrast has been injected? Follow the steps that have been already mentioned in the first presentation. So there are the steps that we need to follow that have been already answered live and during the presentation. This is going to be on video anyway. They can watch it again.
Yeah. Yes, we have recorded this as well. So you will be able to find this in due course on the ISRRT website as well. Thanks again, Tim and Scott, for joining us, and bye to everyone for now. Thank you.